Hello and welcome back, class, to Business 80 Medical Terminology and Anatomy. And today we're going to cover Chapter 9, the urinary system. So let's get into it. The urinary system function and structure. The basic function of the urinary system is to filter blood and waste products and then expel them from the body, remove them from the body. We have two kidneys in most cases. We have two kidneys. The kidneys are responsible for helping to filter the blood, regulate acid and electrolyte balance, helps to regulate blood pressure as well, and then stimulate red blood cell formation. So that's the basic functions of the kidneys. Now we have two different specialists in particular that deal with the kidneys in the urinary tract. The nephrologist, nephro is kidneys, gist, G-I-S-T, is referring to a specialist. So a nephrologist is a kidney specialist. A urologist is a urinary tract specialist. So slight differences there. However, they do work in conjunction with one another. Nephrologists and urologists oftentimes work together on creating treatment plans and diagnoses for patients that are having urinary issues. So you guys can look at the diagrams on your own. Well, the kidneys, which are really small, honestly, the kidneys are only about 4 inches long, and they're very light. If you ever get an opportunity to hold a human kidney or kidneys, what you'll find is that they're fairly light too. They're not very dense. They're located fairly low in the back, between the last thoracic vertebrae and the third lumbar vertebrae. So fairly low in the back, and of course, most of you probably know that some of the first symptoms of possibly having kidney problems or urinary tract issues is low back pain. The adrenal glands. The adrenal glands are important because the adrenal glands sit on top of the kidneys, and they help to influence blood pressure and sodium and water retention by the kidneys. And then what the kidneys do is they help to filter out waste from blood and then recirculate the blood back into our circulatory system. The nephron is the nephron is the functional unit of the kidneys. So its main activities are to reabsorb ions, filter wastes, regulate electrolytes and acid balance. Now, 3 processes occur in the nephron, and the glomerular process is how urine is formed. So urine formation and the glomerulus. So 3 processes in the glomerulus that take place in the nephrons in order to produce urine is filtration, glomerular filtration, tubular reabsorption, and then tubular secretion. And this is the basic way that urine is formed. Hormones and enzymes that affect renal function. This one is actually pretty good. Hormones. The antidiuretic hormone acts on the distal tubule to concentrate urine. So it helps to increase water reabsorption. That's the antidiuretic hormone. Renin regulates blood pressure through sodium retention. Aldosterone regulates both sodium and potassium. And then erythropoietin is the hormone that is secreted to increase red blood cell production. The bladder, of course, stores the urine. I think we probably know that. Micturition is another fancy term for urination or for urinating. The ureters carry urine from each kidney to the bladder to be stored, and then the urethra is the single tube that leads from the bladder to the outside world and allows us to get rid of the urine. Okay, so ureters carry urine from each kidney to the bladder. Okay, after glomerular formation of urine, the ureters carry that urine down to the bladder, and then from the bladder, the urethra sends it to the outside world. Okay, and then I kind of like the last point where it says in males, because we're going to talk about the prostate gland. In males, the urethra runs right through the center of the prostate gland. Okay, so one of the common symptoms for a man that's maybe that has prostate issues is going to be urine retention, or not having a good urinary flow, dribbling, as we like to call it, where it's just not a good urine flow. That could be swelling of the prostate, and if the prostate swells, then it puts pressure on that urethra. It puts pressure on the tube, so then urine doesn't always just flow right out. Okay. All right, physical exam terms. Some of the physical exam terms. Anuria, A-N being absence of. Okay, so anuria, absence of. Azotemia, okay, uremia, excessive urine in the blood, or excess urea. Azotemia is usually excessive blood urea nitrogen, and that's often a sign potentially of one of the signs of renal failure. Okay, and we'll talk about that in a little bit. Dysuria, difficult or painful urination. Of course, we would use this if somebody came in and said, "Hey, it really hurts, when I pee. It burns when I pee." That would be dysuria. That would be the diagnosis today, as far as what's going on. Glycosuria, excessive urine, excessive glucose in the urine. Nocturia is another good one. Excessive nighttime urination. Again, go back to men. That could possibly be from urinary retention because of the swollen prostate, possibly. Okay, or just simply not emptying our bladder before we go to bed. Oliguria is diminished urine output, okay, and then polyuria is an excess of urine output. So olig means diminished or decreased, poly means many. Okay. Proteinuria, pretty basic, right? Proteinuria, excessive protein in the urine. Pyuria is pus in the urine. Okay, oftentimes sign of some form of an infection. Okay, and then we've got the other things like urinary hesitancy, incontinence, the inability to control urine, which sometimes happens to us as we age. Okay, urine and bladder tests. These are some of the tests that we might do. A cystometry checks the bladder's neuromuscular function. Again, this might be something where if somebody's having urinary incontinence and the inability to control urine, we might do a cystometry. Okay, electromyography, that one's a good one. In particular, the external sphincter electromyography evaluates, same thing as the cystometry, could evaluate urinary incontinence by measuring the electrical activity of the urinary sphincter muscle, okay, to see if there's any damage or any potentially just degenerative changes with that sphincter, right? Over time, it's just weakening, that muscle is weakening. What else? Urinalysis, tests for urine, the color, specific gravity, or the weight of urine versus water. Urinary sediment, we can check initial signs or first signs often of a new diabetic is signs of glycosuria through a simple reagent dip with a reagent dipstick. So when we say urinalysis or a urine dip, we're talking about a strip that has about 9 different things on it. And when it comes into contact with urine, it will react and give us information about the urinary system and kidney function. And again, oftentimes for new diabetics, that might be the first way that we wouldn't say make a diagnosis of a new diabetic, but proceed down the road of following up with probably additional blood work to look for true signs of diabetes, oftentimes that first indicator is through excess glucose that's spilling in the urine. Okay, and then urine cultures. Cultures are always looking to identify bacteria. Okay, and oftentimes with urine, we'll do a culture and sensitivity. And I think we've talked about this a little bit before, but if we haven't, the culture will identify bacteria, and then the sensitivity part will tell us what antibiotics work to fight that particular bacteria that the patient might have, and what antibiotics or drugs will not do anything for that particular bacteria. So whenever we culture urine, we almost always do a culture and sensitivity, or we call it a C and S, or a urine C and S. Okay. Other tests that we have, urine and bladder test, urine myoglobin, which is an enzyme that's released by muscles. We may do that. Flowometry measures the volume of urine that's voided, how much urine is being excreted. I don't think we covered, we did 24-hour urine specimens. That's a one that I've done many of those for patients where we collect urine for a 24-hour period. And then usually look for specific substances. I believe they talked about creatinine, protein, uric acid. We're looking for the total amount of that substance secreted during a 24-hour period. And then results from that can give us information as to what disease process might be going on. Okay. We do blood studies. The blood urea nitrogen, or a BUN, as we call it, measures the amount of nitrogenous waste in the urine. This would be a good test to do if we had somebody that was in renal failure, azotemia, that would be potentially leading to a toxic condition in the body, and a BUN, or a blood urea nitrogen test, a simple blood test, would tell us if that's what is actually happening to the patient. Okay. Other things, serum potassiums. Potassium levels, obviously always very important for good heart health, for lowering blood pressure. Same thing with sodium. Uric acid levels. We'll check those for things like gouty arthritis. High or elevated uric acid levels tell us that possibly the patient has gouty arthritis, or gout. Okay. All right, different imaging studies that we do. Obviously, we do pictures of virtually everything. We will do things like CT scans, MRIs. Probably the one that's very specific to us is the KUB, the kidneys, ureters, bladder. It's basically an X-ray that visualizes those structures, the kidneys, ureters, and bladder. Okay. What else? All kinds of different things. Angiography, okay, radiographic images of the renal arteries in the kidneys, renal angiography, venography, looking at the renal veins in the kidneys. Okay, ultrasounds, we do a fair amount of those, and the cystourethropy. Okay, that one's a good one. The voiding cystourethropy demonstrates the efficiency of the bladder filling and then excreting that urine out of the bladder. How efficient is that? Okay, so all of that leads into possibly diagnosing certain disorders, right? Like acute renal failure. Okay, acute being sudden onset, so the sudden onset or disruption of renal function or kidney function. Okay, 3 stages. Okay, 3 stages of renal failure. The intrarenal failure, okay, caused by, or I would say not stages, but 3 potential causes of acute renal failure. Damage to the kidney, okay? Post-renal failure caused by an obstructed urinary flow, and then pre-renal failure caused by any condition that reduces renal blood flow. Okay. Now the phases or stages of acute renal failure. Okay. So usually occurs in three very distinct phases. The oliguric phase. Okay. Remember, olig is decreased or deficient, so a decreased urine output. The diuretic phase, where a high volume of urine is produced, and then the recovery phase, and it says diuresis corrects and azotemia disappears. Diuresis is another term for increased volume or increased output or increased urine production, and then the azotemia is usually the increased blood urea nitrogen, or BUN, and that can cause toxicity. So in the recovery phase, we should see the urine output decrease, and the azotemia as well starts to decrease. Okay? All right, other disorders that we can talk about, benign prostatic hyperplasia, or BPH. Okay, BPH is the abbreviation for this. So BPH is benign prostatic hypertrophy, or a benign swelling of the prostate. Okay, so meaning it's not cancerous, but something is causing the prostate to swell. So again, when we talk about men, a swollen prostate will put pressure on that urethra and potentially cause urinary symptoms, like urinary retention in particular, or lack of consistent flow. Okay. Chronic glomerulonephritis is another good one. Chronic inflammation of the glomerulus, which is usually symptoms that present are going to be decreased urine production, increased fluid retention, and elevated protein levels. Okay. Chronic renal failure, opposite of acute renal failure. Chronic, it's progressive loss of kidney function, which will lead into a couple of things we'll talk about next. Hydrospatius, the urethral opening on the ventral surface. This usually occurs in females. Okay. And it says where the opening occurs within the vagina. So this is a condition in which the opening of the urethra is on the ventral side, so on the front, versus being dorsal or downward. Okay. Nephrotic syndromes, elevated protein levels, low blood albumin, fluid retention. Okay. Cystoceles, very common. Cystitis, very common. Cyst is a term for bladder, CYST. So cyst is bladder. So cystitis is inflammation of the bladder, oftentimes caused by infection, so fairly easily treatable with antibiotics. Okay. Renal calculi, those are kidney stones. Okay. Layman's terms, we call them kidney stones. Medically, we typically call them renal calculi. Okay. Renal vein thrombosis, a clot in the renal vein. Okay. And urethritis, inflammation of the urethra, which could cause, pain with urination, possibly caused by some form of infection. Could be secondary. Urethritis could be secondary to an STD or STI, like syphilis. Okay. Lithotripsy, L-I-T-H, is referring to a stone or a calculi. So lithotripsy, tripsy is to crush or to break up. So lithotripsy is to crush stones. Okay, so that would be one of the treatments we might do to break down urinary calculi or kidney stones, is lithotripsy. Okay, catheters we use fairly frequently for things like urinary retention. If somebody is unable to get the bladder from or get the urine from their bladder to the urethra and to the outside world, then we may place a catheter through the urethra into the bladder and then take the urine out that way, so artificially. Okay. Dialysis, very serious, right? Typically dialysis is performed when we have chronic renal failure. The kidneys or the renal system is continually becoming less efficient over time. Dialysis would be the way that we would filter blood, filter waste, filter the toxins out, because the urinary system is no longer able to do that, or the renal system isn't able to do that. So this is pretty serious, because it means that we are artificially cleaning the blood, right? Artificially keeping good, healthy blood circulating throughout the system. Okay, so dialysis is very serious. Unfortunately, whenever you're doing these artificial things that the body normally does on its own, patients won't live forever on dialysis. At some point, the body will really break down. So this is usually that kind of potentially end-stage renal disease type of thing that we would do, is dialysis. Okay, different types of surgeries. Cystectomy, removal of the bladder or bladder tissue, partial cystectomies, same thing, removal of part of the bladder. We would do this maybe for a bladder that bladder cancer would be a possible scenario, where maybe we have some cancerous tissue in the bladder, so we're going to do a partial cystectomy to remove that cancerous tissue. Okay. Different types, simple versus total. Radical cystectomies. Radical is talking about removing the bladder and some of the surrounding structures around the bladder, so that's pretty serious. Okay. Cystotomy is making an incision in the bladder. Okay. Prostatectomy is the removal of the prostate. Again, it could be partial, it could be a complete removal. We do certain things like this transurethral prostatectomy, a TURP. Okay, it says it uses a resectoscope that goes through the penis, so through the urethra, and then can either be used to visualize the prostate or to remove prostate tissue. In particular, for something maybe like a biopsy of the prostate, in order to make a diagnosis. Okay. Transurethral resection, a TURB, uses a cystoscope to remove small bladder lesions. Okay. And I think we've got... Oh, we don't. I thought we had a picture. I know you've got a picture in your text, however, that shows the, I think a cystoscope gives you a visual of what that looks like. And yes, that was on page 363. They show the cystoscope as it is placed in the urethra, through the penis, and into the bladder, again, to either visualize the bladder or to possibly be used to remove tissue from the bladder. All right, so that pretty much covers most of Chapter 9. Read your text and take your exam, and I wish you the best of luck on that, and I look forward to seeing you for Chapter 10.